But let's turn our next attention, Eric, to something that we all struggle with every day, and that is we've looked at clear cell as an entity inside of kidney cancer. We understand it a little bit better, but there's this whole other group of renal cell cancer patients that have non-clear cell histologies. Interesting, one of the areas that I've spent some time on is the Argos Trial, which is a vaccine trial in the frontline setting combined with sunitinib. And one of the interesting things that we reported at ASCO 2015 is that of the 1,000 patients that we nephrectomized with metastatic disease in preparation for vaccine preparation as a clear cell patient, a majority of those patients had non-clear cell histologies. So it may be that the non-clear cell histology group, at least in presenting with metastatic disease, or even those that we're seeing in our clinics, are becoming an increasing group of patients that we struggle with. So you led some trials at MD Anderson. There's a trial reported at ASCO 2015. So what's your interpretation of the data? What's your interpretation of how it should be applied? And how should we manage the non-clear cell histologies, Eric?
So very, very interesting to hear that how many people have non-clear cell renal cell carcinoma. And I think that's really important because as we start learning more and more about the genetics of these diseases, they're different. So clear cell renal cell carcinoma, there's a VHL mutation, and this is a very angiogenic tumor. Papillary renal cell carcinoma, which is probably the second most common, of which there's 2 subtypes. There's MET upregulation, which is a particular oncogene, which is found in chromosome 7, and is potentially targetable. So there are differences, and these differences potentially can lead to exciting new treatments. But for the here and now, with regards to the therapies that are currently available, my colleague Nizar Tanir and I worked on a trial looking at the comparing sunitinib to everolimus in the non-clear cell population, and this was a population built of papillary renal cell carcinoma, of chromophobe renal cell carcinoma, and various other subtypes, and asking the question of whether or not sunitinib was better than everolimus. And from a progression-free survival perspective, it looked like, by and large, sunitinib was probably better than everolimus. Then if you looked at subsets, we saw that papillary had more modest responses, but chromophobe renal cell carcinoma actually looked like it responded fairly well to anti-angiogenic agents. So this is kind of interesting again to see how these subsets bear out. This year at ASCO we have the Aspen Trial, which is another large randomized study asking a very similar question, and which was very heartening. We see that very similar results arise from this as well. We see that progression-free survival is clearly in favor of sunitinib, and also there's, I think, some early but provocative overall survival data in that patient subset. So I think moving forward, what we need to do is we need to start thinking about how do we treat these subsets. And there are some other data that are being presented at ASCO this year, sort of looking at combinations of anti-angiogenic plus mTOR inhibitors in various subsets. There are trials that are underway looking at MET blocking agents. And I think in the next 3 or 4 years, we're probably going to see some specific therapy for specific subgroups of non-clear cell renal cell carcinoma. And
coming back to you, David, there was a conversation that we had a bit earlier about the possibility that checkpoint inhibitors may not be specific to clear cell subtypes, right, even though we've always talked about clear cell renal cell carcinoma as being the immunologically responsive portion of the disease. Thoughts about that and agents like Nivo and others in non-clear cell histologies?
Yeah, no, I think that if you can get an immune response to a lung cancer, the limits, are much less. If you can get lung cancer to respond, there's many cancers are going to respond, and that's what you see with the PD-1 story at this meeting. We're probably up to now 14 or 15 separate tumors where there's a signal of activity with these drugs. So in my mind, there's no reason to exclude non-clear cell patients. If lung can respond, non-clear cell can respond as well. Our group has looked at PD-L1 expression in non-clear cell tumors, and it's there in some patients. In some tumors higher than others. In a small group of patients, we saw a lot of expression in translocation kidney cancer, which is a big problem for very young people. That would be an exciting place to study these agents, but we should not be excluding them. We're excluding them now based on history. As you mentioned, the conventional wisdom was only clear cell responds. That's an IL-2 story. That's an interferon story. that's not a checkpoint story, and we need to push sponsors of these trials to open up the eligibility criteria and do specific trials in those patients, because it represents 20% of the people who get it, and they need help. They need effective therapies.